I'm happy to bring you the second in a series entitled New CF that really looks at how the advent of CFTR modulator therapy has influenced the management of cystic fibrosis. And here I'll focus on fat-soluble vitamin management. I'd like to start by looking at some data from the CF annual report. The report showed that 83% of the over 33,000 people with CF in the 2025 CF Foundation patient registry were prescribed a modulator. 67% ETI and 11% the newest of the triple therapies. Almost 8 out of 10 people on triple therapy, with 5% on dual therapy. An additional 10% are eligible but not prescribed. And this is probably the most striking point on the slide. Among people with CF born between 2021 and 2025, half are predicted to live to age 66 or beyond if prescribed a CFTR modulator. Unfortunately, median survival is lower by approximately 2 decades for those ineligible for a CFTR modulator. So let's delve down into the data from the JPGN report. It was entitled Effective Cystic Fibrosis Modulator Therapies on Serum Levels of Fat-Soluble Vitamins, published in June of 2025. Importantly, the study was prospective, engaged 14 centers, and included 224 patients to analyze the effect of CFTR modulator treatments on fat-soluble vitamin levels. Diagnosis was between 12 and 18 years of age. Importantly, the protocol was uniform across all 14 centers and 224 patients. So let's look at the levels and how they were measured. So for vitamin D, 25 OHD, they define normal as greater or equal to 30 nanograms per ml, insufficient 20 to 25 nanograms per ml, deficient less than 20, and toxic at greater than 100 nanograms per ml. For vitamin A, normal values were defined as 30 to 70 micrograms per DL, E, 500 to 200 micrograms per DL, and vitamin K was not measured. Baseline clinical and demographics they reported were similar, whether dual or triple therapy, except for age, genotype, and isolation of Pseudomonas. And they offered this was likely due to the approval of different modulator therapies for different age groups and genotypes, and that PA colonization is more prevalent in older age groups. So let's take a look at vitamin D. The ETI group shows statistically significant changes in vitamin D levels at baseline to 6 months and 12 months, but not 6 to 12, which suggests that perhaps these changes occur early between the fat-soluble vitamins and modulator therapy. The ETI group showed a progressive decrease in insufficient vitamin D values at baseline, 64%, dropping to 45% at 6 months. Baseline to 12 months, 61%, down to 48%. The ETI group also showed a progressive decrease in deficient vitamin D levels. Baseline to 6 months, 23 to 10%. Baseline to 12 months, 28 to 15. No differences were found between 6 and 12 months. The dual therapy group showed no differences in vitamin D levels, and there was no change in vitamin D doses throughout the course of the study. So let's look at the results with vitamin A. Overall, there was an increase from baseline to 6 months and baseline to 12 months. The increase was higher in the ETI group versus the dual therapy. And the ETI group maintained this change at 12 months, but this increase was not maintained in the dual therapy group. The ETI group showed a decrease in the proportion of deficient vitamin A values, baseline 21%, 6 months 6%. And the ETI group also showed an increase in vitamin A toxicity. Let me say that again, an increase in vitamin A toxicity at 6 months, baseline 3%, 6 months 11%. No differences were noted in the dual therapy group. All patients had normal vitamin E values, and no significant difference were seen in serum vitamin E levels between these two groups. So let me now share with you the author's discussion. They note that monitoring of serum levels of fat-soluble vitamins and adjusting doses accordingly should be a regular part of CF management. Treatment with ETI results in a significant increase in A and D levels within the first 6 months, with these improvements maintained at 12 months. It's also important to note the proportion of patients with retinol levels in the toxic range after starting ETI. And patients with elevated vitamin A levels often do not show symptoms. So clearly in their discussion, they recommended using a vitamin A in the form of beta-carotene, a precursor rather than retinol, preformed vitamin A, to minimize or avoid toxicities. So we're clearly in a new era of new CF, an era ushered in by the advent and high use of triple therapy, particularly ETI. Monitoring of CF-specific multivitamin fat-soluble levels within the first 90 days and use of a CF-specific vitamin with a high percentage of beta-carotene content manage these risks associated with potentially elevated and toxic vitamin A levels. With the majority of patients in the U.S. receiving triple therapy versus dual therapy, this becomes even more of an imperative. Fortunately, these options exist.